1 o'clock. Everyone hopefully is back. We'll take a quick roll call. Um, Maria, are you back?
I am back.
Hi, Maria. Indira, I see you. Hi, Indira, and I see Nicole as well. Welcome back. All right, everyone. So now let's get right back on it. Continue on agenda item 5. We're going to introduce and welcome Dr. Richard Dang with the California Pharmacists Association. Dr. Dang, floor is yours. I don't see him, but I see he's promoted. There it is. All right. Thank you. The floor is yours.
Thank you. Hi, everybody. Hopefully you had a great lunch, and thank you to the board and the committee for inviting me to present, and thank you for your time today. My name is Richard Dang, and I'm the president of the California Pharmacist Association, the largest state association representing the pharmacy profession in all practice settings in California, including community pharmacy, both independent and chain settings, hospitals and health systems, and specialty practices, including compounding, managed care, and long-term care. And the mission of our association is to advance the practice of pharmacy for the promotion of health. In my professional life, I'm actually also faculty at the USC School of Pharmacy as an assistant professor and a residency program director of our postgraduate training program in community-based pharmacy practice. And I practice at our outpatient USC pharmacies and pharmacy-based clinics. Next slide, please. Just a little bit of an outline for my presentation today. We've heard some really great presentations earlier this morning from the Attorney General's Office, NABP, and Dr. Robinson as well, talking about the standard of care. So I'll just briefly highlight and touch upon and reinforce some of those concepts. And in order for us to adequately consider standard of care, I think it's also important for us in the committee to discuss the history of pharmacy practice in California. So I'll be reviewing a little bit about how we got to where we are today over the last 30 years as the pharmacy profession has evolved from a product-centered profession to a patient-centered profession. And then I'll bring some case studies to help us conceptualize what standard of care might look like in a patient care setting in various patient care disease states. Next slide, please. So as you already heard from the Attorney General's office, our current model is considered a rule-based direct enforcement model. And again, this model that we currently have, some of the cons is that it is very restrictive and prescriptive. Pharmacists are bound by specific practice allowances in the law on how and what they can practice. And these are also interpreted through state statutes and Board of Pharmacy regulations, as you're familiar with. Anytime we need to make any changes to state statutes or regulations in order to meet the current best practices, we have to go through a very lengthy process to propose new legislation, propose new regulations, and that can be very timely. Best case scenario, it can take up to a year to implement, but as we know, it can take several years for certain regulations to be reviewed, discussed, proposed, and approved. Additionally, statutes and regulations that are outdated and no longer applicable also need to be reviewed. And again, that can cause some confusion with the conflicts between the statutes and the current best practices in medicine. Next slide, please. And you also heard the definition of standard of care, which I won't read off as you're familiar from the previous presentations, but the definitions presented on this slide here from NABP are also consistent with the other definitions that have been used in other areas. Most notably, there is the definition from the National Institute of Health, and as well as from a journal article from the American Medical Association. And essentially, standard of care simply refers to healthcare providers being able to practice in line with their training and their competencies. Additionally, I do, based on the discussion mentioned earlier, I do want to also highlight that for us, standard of care is really related to the authorized scope of practice regulations in the state of California. We're not looking to impact or significantly change the regulations or standards for pharmacies, facilities, or other licensed entities. And I know that was part of the conversation earlier this morning. Next slide, please. And you've also heard about the use cases. There are several states that have already implemented the standard of care model, most notably Idaho and Washington. Both of these state boards have converted over to the standard of care model for a few years now, beginning as early as 2016. And I know that board member Nicole had asked a question about were there any changes to data about patient safety. I'm not familiar with any, but if there are, I will look to those two states to see if there were any changes in disciplinary actions or patient safety that may have occurred. As far as I'm aware, there haven't been any significant patient safety issues that have arisen from these two states as a result of their conversion to the standard of care models. Additionally, within our own state, we do have existing models with the Medical Board of California and the Board of Registered Nursing, as you also heard from the Attorney General's office. So it would not be a new concept for our regulatory agencies within the state to apply a standard of care model to another healthcare professions board. Next slide. So some of the benefits, standard of care model would allow pharmacists the necessary flexibility within their scope of practice to make the best determination as healthcare providers on how to take care of their specific patients. It also allows for the progression of the practice of pharmacy to transition to a more direct patient-centered care model, for example, through comprehensive medication management and medication therapy management services. In addition to the benefits to the individual practitioners, there's also a benefit to the Board of Pharmacy. So the standard of care allows the Board of Pharmacy to establish a clear regulatory framework that is consistent with those of other healthcare providers for the oversight, regulation, and enforcement of direct patient care services that will most effectively protect the public. Next slide. And so with those definitions out of the way and reinforcing some of the presentations from earlier, I do want to shift and talk about some of the history of the evolution of pharmacy practice in the state of California. And again, how we moved from a product-centric to a patient-centric profession, more than a few decades ago, and historically pharmacists are associated with dispensing of medications. And that remains to be a foundational responsibility of our profession as well. But in California specifically, we really started turning the corner in the 1970s. So in 1972, there was a bill, AB 1717, that created a pilot program in California that allowed certain pharmacists in certain settings to adjust drug therapy for certain patients in certain conditions. And specifically, it was primarily looking at anticoagulation clinics associated with hospitals and health systems. As a result of the success of that pilot program, which was called the California Health Manpower Pilot Project, we see over the next few decades that there were several key legislative moments that continue to expand the ability of the pharmacist to have expanded scope in the area of prescriptive authority. So in 1981, we had AB 1868, which further expanded the initial authorities granted in 1972 to expand the prescriptive authority of pharmacists to all healthcare facilities. So instead of being the specific pilot clinics that were identified, it was further expanded to all healthcare facilities, acute and intermediate healthcare facilities. Then in 1983, that authority was further expanded to any licensed healthcare facility. And then in 1994, that same prescriptive authority allowing pharmacists to initiate, adjust, and modify drug therapy further expanded to ambulatory care clinics, health systems, and healthcare plans. And that was really, the beginning of what we now know as collaborative practice agreements and protocols. And so we can see that as early as the 1970s, we were seeing these benefits of pharmacists being able to provide these types of services. And because of the positive results that we were seeing, that we continually saw changes in the legislation and in the regulations that allowed pharmacists to provide these services. But it was also limited to a number of various practice settings and disease states historically. But again, that has expanded and changed over time. Next slide, please. Now, with the modern changes in pharmacy practice, these are some of the highlights here. So in 1996, there was a bill that permitted pharmacists to be paid for non-dispensing activities by healthcare service plans. And that was another big moment as well, recognizing that pharmacists are able to provide these services and that they are reimbursed for these services outside of dispensing a medication product. In 2003, we saw bills that authorized pharmacists to furnish emergency contraception, which included medications like levonorgestrel or Plan B. Then in 2012, we saw the authority of pharmacists expanded to be authorized to independently perform certain CLIA wave tests, specifically for blood glucose, hemoglobin A1C, and cholesterol. And these two bills in 2003 and 2012 are really the foundation of SB 493 and all the modern bills that we have seen over the last decade. So many of our board members are familiar with the 2013 legislative bill, SB 493, which was a very significant recognition and expansion of the scope of practice. SB 493 did several. Foremost, it formally recognized the pharmacists as healthcare providers in the state of California. And so we are defined as such, and also as such, we should be regulated in the same way that other healthcare providers are regulated. In addition to that, SB 493 granted additional prescriptive authorities for pharmacists to initiate or administer routine immunizations and furnish medications for self-administered hormonal contraception, nicotine replacement therapy, and international medications needed for international travel. It also granted the authority to order and interpret tests for managing and monitoring drug therapy, and it granted the authority to administer drugs and biologics pursuant to a prescriber order. And of course, it established our advanced practice pharmacist designation. So this was a big expansion that built upon the last few decades that really recognized the ability of pharmacists to be able to provide these services. Next slide. And now what we see is an acceleration of the further development and evolution of the profession of pharmacy in California. In 2015, we had AB 1114, which added payment of these pharmacist services to Medi-Cal coverage. And so the state is paying for select services that are being offered by pharmacists for these clinical activities, again, outside of the dispensing of a medication product. And in 2019, we also received further authority to furnish HIV PrEP and PEP, or pre-exposure and post-exposure prophylaxis. And also, actually, in the previous, I forgot to mention, pharmacists also received the authority to furnish naloxone for opioid reversal. So we see that over the last 10 years, there was a very rapid evolution of the scope of practice and what pharmacists are providing. And with every single change came a process of going through the legislature, of going to the Board of Pharmacy, of approving and regulating regulations, of creating detailed protocols that outline step by step what should and can be done by pharmacists when executing these services. In the last 2 to 3 years, there have been even more changes and evolution to the profession of pharmacy as a result of the COVID-19 pandemic. And I think that the COVID-19 pandemic really revealed the need for the profession and the board to be nimble in order to respond to emergent issues that may arise that are both expected and unexpected. So in 2020 and 21, we saw several issues arise related to testing, immunization, and treatment of COVID-19. And as a result of our restrictive regulatory process in California, we pharmacists were not able to contribute to the COVID-19 pandemic response without significant efforts from the Board of Pharmacy, DCA, and the state to request waivers and executive emergency orders to allow for pharmacists to perform these services that were so crucial during the pandemic. Additionally, these waivers and executive orders, some were expired and some were temporary, but others were taken up by the legislator to make it more important because everybody understood that these were important authorities that needed to be made permanent moving forward. And specifically, that was around both immunizations and testing. So we had AB 1710 and AB AB 1064, which both address the immunization issue. As you recall, with SB 493, pharmacists were authorized to initiate and administer routine vaccines. However, with the COVID-19 vaccine at the time, because it only received emergency authorization from the FDA, it was not considered a routine vaccine, meaning we had to go through this detailed regulatory change in order for pharmacists to be able to administer these vaccines. And we know that as of now, pharmacists are one of the top providers of immunizations, COVID-19 vaccinations across the nation. But as a result of these changes, especially with 1064, pharmacists now have the authority to initiate and administer any FDA approved and CDC recommended vaccine. So I do want to point out that if we take a kind of a narrow perspective on vaccination, this is standard of care. We currently have standard of care when it comes to vaccinations for pharmacists. Basically, as a result of these new regulations, what we're saying is that any pharmacist who is appropriately trained can provide any vaccination service according to the best practices recommended by the CDC and other peer institutions. And our conversation is about expanding that standard of care model to all disease states and all practice settings, and not just focusing on one particular area. But I do want the committee and board to recognize that we do basically have standard of care with vaccinations now as a result of 1064. In addition, we had SB 409, which was a Board of Pharmacy sponsored bill that expanded the pharmacist's authority to perform CLIA wave tests beyond blood glucose, A1C, and cholesterol, which did include certain tests such as those for HIV, hepatitis C, and influenza and COVID-19. As we look into 2021, you're familiar with AB 1533. While that was the sunset review bill that did include a lot of items in there, there were a few that were also related to the scope of practice. Most notably, AB 1533 expanded the practice settings where collaborative practice agreements could be used to any practice setting, including community pharmacies. So it's no longer restricted to just simply ambulatory care and healthcare facilities. AB 1533 also granted pharmacists to provide medication-assisted therapy to help with addiction treatment, and also granted the authority of the advanced practice pharmacist to initiate, adjust, and discontinue drug therapy without the restriction of previous regulations requiring a CPA and protocol. So you can see that, again, over the last few years, really rapid evolutions that were in response to a lot of emergent issues that came to light as a result of the COVID-19 pandemic. Next slide. And we do continue to have a healthcare shortage, not only in medicine and nursing, but just throughout the healthcare system. And we've heard these concerns for many years now, but it's still true over the last few years. And if anything, these shortages are being exacerbated by the COVID-19 pandemic as we have provider burnout and staffing shortages across the states. Most notably, UCSF has conducted a study, and as a result of their study, they found that California demand for primary care providers will continue to exceed supply by 2030. Next slide. And in that study, there was a quote from Dr. Janet Hoffman, and it says, and hopefully you're familiar, that California faces a looming shortage of primary care clinicians in the coming decades. And if we continue along our current path, more and more Californians will need to visit the emergency room for conditions like asthma, ear infections, and flu because they lack a primary care provider. Pharmacists are well equipped to assist the states in addressing this primary care shortage. Arguably, a lot of these acute care conditions like asthma, ear infections, and flu can be addressed and managed in a community pharmacy setting with appropriately trained providers. And the scope of practice model will allow us to address this pressing issue. Next slide. So overall, one of the greatest benefits of standard of care is allowing the profession, the Board of Pharmacy, and the state to keep up with rapidly changing science and medicine, and to keep up with new evidence for the provision of the best possible medicine to patients. And this is especially important as the non-dispensing role of pharmacists in direct patient care services has become more prominent over the last few decades. And as pharmacists are increasingly becoming a part of the patient care team, it makes sense to, at a minimum, adopt a form of regulation that is consistent with other healthcare providers who are treating the same types of patients, conditions, and situations. You saw from the NABP report their recommendation and how other health profession boards are approaching the standard of care. And again, as science evolves, it's important for both the profession and the board to be able to keep up with new evidence as they come to light. Next slide. So given the evolution of the practice of pharmacy in California over the last 10 years, the last 10 to 30 years, CPHA believes that it is appropriate to adopt and begin transitioning pharmacy to a standard of care model that allows both pharmacists to be able to practice at the top of their license in direct patient care and to give the Board of Pharmacy sufficient and necessary tools to continue protecting patients in California. Next slide. The association also has several policy statements that are in support of the transition of the standard of care model. I won't read every single policy statement on this slide, but I do encourage the board to take a look at some of these. I will point out a few, including that the California Pharmacists Association supports the establishment of standards of practices that are adopted by the profession to assure the health and safety of the public. The association encourages pharmacists to seek advanced training, and we support limiting prescribing authority to the prescriber's recognized scope of practice. And finally, we believe that pharmacists shall provide pharmacist care services and referrals that are consistent with the health needs of the patient and that are commensurate with their level of training, skill, and experience. Next slide. We talked a little bit about the benefits to the board and to the profession, but there's also benefits to the state and to the public. By moving to a standard of care model, some of the benefits include allowing pharmacists to provide direct patient care services, and by doing so, reap the benefits that we have seen in the data that has been published over the last several decades. By allowing pharmacists to provide these patient care services, we can address the healthcare challenges that faces the state, including primary care shortages and high healthcare costs. And we know that when pharmacists are engaged in these disease state management programs, that there are improved health outcomes. We see, for example, improvements in blood pressure and blood glucose. And we also will have increased access to healthcare providers, especially in rural and underrepresented areas. So especially for those areas where they may not have access to primary care or other healthcare services, the pharmacists and pharmacies may be appropriate locations for them to receive their necessary care. Next slide. With all of this, as we think about how we would evaluate a pharmacist using the standard of care, there is the Joint Commission on Pharmacy Practice pharmacist patient care process. And this is the framework for how pharmacists are to deliver patient care services across all practice settings. And I want to point out that at the center of the process, and the next slide, you'll see it enlarged, at the center of this process remains to be collaboration, communication, and documentation in the best interests of patient-centered care. So even though pharmacists will be able to provide services through standard of care model, collaboration with other healthcare providers and entities remains a core tenet of our patient care services. Next slide. And so with that, I want to talk about some case studies so that the attendees and the committee members can see how standard of care could be applied in certain scenarios. So in this example A, we'll be talking about a pharmacy-based point-of-care testing model and the test and treat model, which has been in the news recently because of the federal government's plan to address COVID-19. So in this process, we have a patient who is coming to the pharmacy to request a point-of-care test. And as a result of the recent Board of Pharmacy sponsored bill to expand pharmacist authority in this area, this pharmacy is offering a point-of-care test for influenza. The patient receives the influenza point-of-care test and receives a positive test. What we know clinically is that when a patient tests positive for influenza, there is a medication, an antiviral medication, oseltamivir, that can be started that is known to reduce symptoms and to reduce hospitalizations and reduce other morbidity and mortality benefits. But the medication is only effective if it is started within a certain period of time, within 72 hours. So time is of the essence. So I will go through two pathways. At the top would be status quo. Under the current regulatory framework for California pharmacists, if this patient tests positive for an influenza test using a point of care test that I've provided in my pharmacy, my only option is to refer the patient to a local urgent care center, emergency room, or their primary care provider to then receive a prescription for oseltamivir so that they can be treated for their condition. However, this may lead to significant delays or added costs. When we refer to their primary care providers, their providers may or may not have appointments for the next 1 to 6 days. And then they have to go schedule the appointment. They have to go to another clinic to attend the appointment. Then they have to be evaluated again. Then they receive a prescription. And once they receive a prescription, they leave the clinic and come back to the pharmacy to then get their prescription filled. So hopefully you can see how in this case, it is not ideal because treatment has been delayed, potentially beyond the optimal time of 72 hours from the onset of symptoms for the best benefit of the medication. Now, under the standard of care model, what could happen in this situation is more immediate, more rapid, and more nimble. For the pharmacist who is conducting the point of care test, if they are appropriately trained in managing acute respiratory illnesses, instead of referring them to a primary care provider, urgent care center, or emergency room, that pharmacist could then make the clinical judgment to furnish the prescription for oseltamivir for that patient at the moment they receive the test results. And thus, the patient immediately gets their prescription, they get their prescription filled, and they can start taking the medication immediately as soon as they've been recognized as having a positive test from that point of care test, and thus improving their chances of a more optimal outcome to reduce the severity of their influenza illness and to reduce the duration, the number of days of their illness, and hopefully return to work or school on a much earlier time frame. So through the standard of care model, we can see that there's great potential benefit to the patient care outcome to this individual. The next case study I don't have a slide for, but it is referring to our smoking cessation and nicotine replacement therapy. As I mentioned, SB 493 allowed pharmacists to furnish nicotine replacement therapies to help patients quit smoking. And so that was a great recommendation at the time. And so this is an example of how standard, best evidence is now moving much faster than our current state regulations. So in the area of smoking cessation, the previous updates that SB 493 was based on was the 2008 recommendations from the US Public Health Service. But in 2018, the American College of Cardiology, and in 2020, the American Thoracic Society released new clinical practice guidelines that recommends prescription medications like varenicline as the preferred treatment over monotherapy with nicotine replacement therapy. So essentially what that means then is now that under our current regulations, under the current model, because it's very prescriptive of what we can furnish, pharmacists are not able to furnish the preferred therapy for smoking cessation because varenicline was not included in the current state protocol. As a result, pharmacists who are wanting to help patients quit smoking through nicotine replacement therapy or other products are now potentially exposing their patients to suboptimal therapy, delay in therapy, or worse outcomes. But through the standard of care model, appropriately trained pharmacists in the area of smoking cessation can adapt to these new recommendations and new evidence and furnish the appropriate medication that is now considered first line. And so we see that the model is flexible and responsive to changing medicine. Next slide. And finally, our last case study, I will talk about three, and some of the information unfortunately didn't seem to transfer in the PDF that we have here. But in this case study, we'll talk about 3 different pharmacists with 3 different expertise and how they might approach the same patient. So we have a patient who comes to the pharmacy to pick up their usual prescription for metformin and insulin. During the patient consultation, the patient tells the pharmacist that they have not visited their primary care provider for the last 1.5 years and that their blood sugar readings at home have been high. So let's talk about how each pharmacist might approach this patient in the community pharmacy setting. The first pharmacist has been a pharmacist for 15 years and has received a certificate in medication therapy management. The second pharmacist on the slide is a pharmacist with 25 years of experience and with a certificate in MTM and immunization, and is also a certified diabetes care and education specialist. And our third pharmacist is a pharmacist with 8 years of experience with residency training, MTM and diabetes management certificate, and as a board certified ambulatory care pharmacist. So through the standard of care model, we might see different actions taken by each of these pharmacists for the same patient. For our first pharmacist, who has been practicing for 15 years with an MTM certificate, this individual may potentially choose through the standard of care model to conduct a point of care test to evaluate for blood sugar or A1C. And then based on the result of that point of care test, make a recommendation to the patient's primary care provider to adjust certain medications and to encourage the patient to follow up with their primary care provider since it has been more than a year since their last follow-up. Through the standard of care model, the second pharmacist, who is a certified diabetes care and education specialist, may actually choose to recommend modifications of the medications or may choose to furnish new medications in accordance to the American Diabetes Association guidelines so that the patient can immediately receive access to the proper medications to keep their blood sugars under control. And similarly, the third pharmacist, who is also board certified ambulatory care pharmacy, may also choose to take the same actions with the active role of disease management for that particular patient, again, to give them immediate access and immediate benefit to medications so that their blood sugar, which seems to have been uncontrolled, can immediately be controlled through the changes of the medications that were initiated by those experienced pharmacists with that training. And with all of that, in either scenario, the pharmacist will always work in coordination and collaboration with that patient's primary care provider as a part of the care team. Next slide. So in summary, again, CPHA does support the transition to a standard of care model, and we do view the standard of care model as not being a one-size-fits-all. Standard of care is dependent on the pharmacist. It is dependent on the practice setting. It is dependent on the patient-specific factors that may be at play based on the patient's past medical history, laboratory information, etc. Standard of care is also not an open-ended authority for pharmacists free from oversight and enforcement. And in fact, the Board of Pharmacy will play an important role in establishing the boundaries and the framework for how pharmacists will practice under this model. Standard of care also does not overhaul the regulatory framework for the existing oversight and existing authorities related to dispensing activities. And again, we're not looking to necessarily change to a standard of care model for facilities or entities. Standard of care, on the other hand, does allow for pharmacists to provide direct patient care services that are commensurate to their training to optimize medication therapy and to improve health outcomes. It also allows pharmacists to provide individualized patient care that would benefit the specific patient that's in front of them with the specific situation and condition that they are encountering. It also allows pharmacists to rapidly respond to evolving or emergent needs of Californians. And overall, the standard of care model would allow the board to benchmark pharmacist performance to the best practices of peer providers, such as those of other equally trained pharmacists and other medical providers in similar situations. And I do want to emphasize that the standard of care benchmark is not established by employers or corporations. They are established by comparison to peer individuals. And finally, the standard of care model would allow the Board of Pharmacy to create appropriate regulatory frameworks for patient care services that appropriately protect the public. Next slide. Oh, that's my last slide. And so with that, thank you for your time and thank you for listening to my presentation. And I will turn over to Chairperson O to see if there's any questions.
Thank you, Dr. Tang. Thank you for the very informative presentation. Members, any questions or comments for Dr. Dang? Please raise your hand if you do. And I would imagine there will be a lot more questions for you if you don't mind staying around during the our discussion section after one more presentation. So thank you so much for your time and coming on board. All right. So with that, moving on to the next presentation, and our last one is Dr. Shane. Dr. Shane is a Vice President of Chief Pharmacy Officer for Cedars-Sinai Medical Center. Dr. Shane, the floor is yours. Thank you again for joining us.
Thank you.
A little too fast. There you go. Okay.
Okay. Thank you. It's been really a pleasure to listen to the presenters today. I think this has been an invaluable educational effort for all of us. I actually, it's interesting. I was reflecting as I was listening to the presentations, and one would think, having been involved in lots of programs myself, that this was orchestrated, right? An orchestrated, planned, rehearsed, organized session today. And yet what I've found and what I've learned, and hopefully what I'll do as the closer, and I promise I won't take a half hour, is to just emphasize and underscore what previous speakers have said, all on behalf of how do we advance the practice of pharmacy on behalf of our patients in a way that's safe, effective, that doesn't compromise safety in settings, that isn't set forth by employers to make it more challenging to provide safe care, and fundamentally to exercise and leverage the knowledge and skills that we possess in the pharmacy profession, because that's what our patients need. So I don't have that much new to add. So that's the good news. And hopefully I can get through this and maybe highlight a few things that weren't highlighted, and get to the discussion section. So next slide, please. So my practice side is a health system. I've been here as an intern. So I have, always say to a lot of the folks that I mentor is, listen, I've been here longer than you've been alive. But what I've really fundamentally learned is how critical the role that we play is for our patients. I mean, the complexity of medications, I often joke, when I got out of school, we only had a half a dozen, right? So it's been a long time, but there continues to be unmet patient needs. And the purpose of the slide was just to underscore what has been reflected by previous speakers. We continue to have a senior population that's expected to double within the next 8 years. These patients are going to need care. They're going to need a translator, someone who can interpret the complexity of the medications in the context of the patient. And if we look at the American population as a whole, approximately 50% of Americans have greater than one chronic condition, and that number continues to go up as people age. And our population in California, actually 15% of Californians are 65 and older. So clearly within our state and across the nation, the expertise that pharmacy brings to the table is unsurpassed by any other professional, because that's where our training is dedicated, as speakers before me have articulated. And certainly in my practice here at Cedars, which has been since I was an intern, I continue to marvel at how much we bring to the table and create expectations on the part of clinicians they didn't have, because they had no understanding of the knowledge and skills we bring when we look at that patient and we see what's wrong with those medication orders. And so I think that, for me, is the reason that I welcomed the opportunity to be a part of this program today, and hopefully the continued work that is the state board has initiated to see how to look at how a standard of care model can actually meet the needs of our patients. Next slide. So contemporary pharmacy practice, we thought it would be of value and to share some of the things that really exist across professional organizations. Next slide, please. Some of this has already been shared, but I just wanted to highlight a few things. I think the oath of the pharmacist was one of the early comments that Dr. Robinson shared, so I'm not going to repeat them, but fundamentally, we're here to ensure optimal outcomes for all our patients. Some of you may be aware that 11 years ago, there was actually a very significant report that was written to the U.S. Surgeon General by the U.S. Public Health Service, really focusing on the need to maximize the expertise and scope of pharmacists. This is a significant evidence-based review. I can't remember if it was 150 pages or 250 pages, but what was interesting is at the time, Dr. Regina Benjamin responded and really did support expanded pharmacy practice models for patients and for health systems, and really recommended the policymakers determine methods to optimize pharmacists' role. If we go across to the Center for Medicaid and Medicaid Services shortly thereafter, within health systems, CMS did come out to broaden what the concept of the medical staff was to allow hospitals to give practitioners, such as pharmacists, the power to perform duties that they are trained for. So throughout today's discussion, we continue to talk about being able to leverage our knowledge and skills and education to support what our patients need. The VA model is well documented and really does support autonomy and independent decision making as part of the scope of practice of pharmacists, and that's done in collaboration with the medical staff, as other speakers have communicated. Dr. Deng talked about the CPHA's statements, and then there's some others as well from the American College of Clinical Pharmacy and the American Society of Health System Pharmacists. So the themes are really about the same. How do we ensure the best use of medications for our patients, particularly as we look at the aging population, the types of diseases for which there are therapies that previously didn't exist that are extremely complex. One can't just initiate some of the biologics and therapies that are available today without really having a pharmacist ensure and be the guardian angel of the medication use process for those drugs. Every aspect of those drugs, from how they're handled to how they're prescribed to how they're monitored, does require expertise. Next slide. The dimensions of pharmacy practice are pretty vast, and I'm not going to go through each of these boxes for the sake of time, but I think we need to respect what pharmacy is. I certainly do, because I've seen these bubbles grow in my career, and they continue to grow in the areas where we've identified so many aspects of healthcare where we need to be a part of that, and so the complexity of everything from our supply chain to the explosion of investigational drugs, to the practice in community pharmacies, to cancer centers, to compounding, continue to grow and grow and grow in terms of importance. And that's what the pharmacy profession brings to the table, and that's what the pharmacy profession brings to our patients. Next slide. So I thought it might be of value. We thought, so we did this as a team. I say I'm an only child. I really have to always correct myself. It comes from being an only child, but there's no I, there's only a we. And there's no such thing as a department of pharmacy. It's about individuals who care enough to do the right thing for patients. So I say there is no such thing as a department. It's one person at a time who cares. So the American Society of Health System Pharmacists conducts surveys periodically just to understand what is the standard of practice in hospital pharmacy. So what you have in front of you is data from the 2018 and 2019 national survey, just kind of highlighting what percentage of pharmacists in the survey are already practicing in these various areas, whether it's authority to write medication orders, select products and dosing, order serum medication concentrations, use clinical surveillance data, assist with daily patient monitoring. And certainly in California, we have the ability to do this already, given our regulations. But I think what's fundamental is the fact that we work in teams, and that we have the electronic health record as the context to enable us to make decisions as a result of that. Now, I have, please do not take this presentation as being only focused on health system pharmacy, because we also manage outpatient pharmacies in my organization, and I respect the work that all pharmacists do. And as Dr. Deng outlined, there may be different standards of practice depending on one's practice setting and or one's training. But nevertheless, everything that is done within the standard practice of a particular setting is done to support patient safety and the best use of medications. Next slide. So again, this is a repeat of Dr. Deng pointed out this wheel, so I'm not going to go over it, but I thought it might be useful to share just some of the things we do in our organization that have all been approved through our Medical Staff Pharmacy and Therapeutics Committee as illustrative of the kinds of work that pharmacists are doing to ensure safe medication use. Within our department, there is actually a service plan that provides a list of those things that each patient receives throughout their inpatient admission to ensure the quality and safety of their medication regimens. We have also a many-page auto substitution list to support not only shortages, but formulary standardization. We do a lot of dosing per pharmacy protocol, all approved again, to support the best use of antimicrobials and anticoagulations. And in fact, when we analyze the data with respect to the interventions that the pharmacists make on a regular basis, when they have time to document, we see so many opportunities to improve management of antimicrobials and anticoagulation, because busy clinicians are sometimes not able to look at these medications in the same with the same perspective and background that we have. And in fact, our medical staff have delegated a lot of this to us. They would prefer we do it. I mean, there have been times the medical staff has asked us to dose things where we've said, no, we can't dose everything for you, but they really do rely on us because they're busy. They have many patients to see. And particularly, as was described very eloquently by a number of the previous speakers, the COVID cloud has kept everybody hopping. And so we've been the safety net in that whole process. And some of the things through COVID therapeutics that we learned really enabled us to ensure safe use of drugs when we were still trying to figure out which drugs we should be using based on the evolving evidence and what I would call the art of treating COVID. We do a fair amount in the area of clarification of medication orders. One thing I can tell you is physicians actually appreciate the fact that we have policies and procedures to support what we would call a standard of care, but every single thing that we do is within that policy. And I have this physician who reaches out to me about once every 6 or 7 months complaining of why are we calling him when there are things that we're doing that we should just do. He doesn't want to be bothered with it. So in fact, physician disruption has been one of the reasons we really believe that a standard of care approach would actually support not only the best use of medications and safety, but would actually not only reduce disruption. Sometimes we have to wait for a physician to call back when we actually know what the intent is, because it's self-evident from the order. Doctors might order a drug by the wrong route because they don't realize they can't give it by that route. They may order a drug in milligrams, but it comes in micrograms. They may forget to discontinue a drug when another drug is ordered, because we have a polydoc phenomenon that happens in US healthcare where there are multiple doctors taking care of a patient and they may not look at the previous orders. So there's so many times where we are calling physicians where we're actually interfering with their care of patients and sometimes annoying, which is why we've endeavored where we can to have a policy on clarification of orders. Next slide. So here are some examples of work we've done where why a standard of care model matters. We found that a lot of our patients were staying in the emergency department because, like most hospitals in the US and in California, we didn't have any beds to move them to. So we actually conducted a study whereby we got approval for a protocol to have pharmacists redose patients who had pneumonia and sepsis if they could not get to an inpatient bed. We were actually surprised that the study demonstrated reduction in mortality. It was actually published in the emergency medicine literature, and there were major reduction in delays in antibiotic administration, which was statistically significant. And what was most surprising is that actually about half the patients had sepsis, so the mortality benefit was very, very significant. We did another study to convert patients to oral antibiotics to reduce length of stay for patients with stable bacteremia. We were able to convert 25% of patients, and we saved 611 bed days. Since we are always full, this was very, very significant, and the study was done during the COVID period. You've heard me present about our work with admission medication histories, and thanks to your support, that's required in the state of California, so we know that about that work. And we've also done post-discharge follow-up calls because we find that patients are confused about their medications when they leave the hospital. Sometimes there are errors on their discharge medication list, so we've been working over the last year to try to improve those. And we actually were able to demonstrate that with respect to medication-related readmissions, which we're calling MACEs, medication-related acute care episodes, we prevented approximately 27.9 readmissions by resolving some significant drug-related problems. So just in terms of standard of care, these are the kinds of things that we're doing in our organization, and other organizations as well are involved in these and other types of initiatives that make such a huge difference on patient outcomes, that the model would enable us collectively to enhance the care we provide to our patients. And I'm sure there's many other examples across different sites of where pharmacists practice. These are based on the health system site where we are. Next slide. So regulatory landscape, this will be quick because you've heard it all. Next slide. We along with the other presenters before us, took a deep dive into the different boards to understand how standard of care was being applied. So I will not spend time on this slide, but we found our conclusions were the same as what's been reported by our other speakers today. Next slide. We also took a deep dive into allied health professionals, because more and more we're seeing in our organizations physician assistants and nurse practitioners, and we were surprised that the scope in terms of what PAs and NPs can do is broader than we can do. So we selected out some languages to highlight kind of what is kind of concerning, given how much training we have in the area of drug therapy, and it was previously articulated. The state board has approved a number of opportunities for us to provide advanced care to our patients, but it's one regulation at a time, one change at a time. Whereas NPs and PAs are allowed to pretty much practice within the scope of their educational preparation and/or competency, using a standardized practice approach or with practice agreements. So it seemed like such a contrast that we're allowed permitted procedures with prescriptive provisions. Sorry, that's a mouthful. Whereas other allied health professionals have much broader authority based on their educational preparation and their competency. So that just kind of was so much of a contrast. We felt that it needed to be highlighted, given how much training we have in the area of medications. That's what we spend our entire educational careers on, or educational training, and then postgraduate training and education as well. Next slide. So we did pull a few things out from Idaho for the sake of time, and because we have talked about Idaho, I just wanted to highlight a couple of things here. But it does show you kind of a couple of different elements of how pharmacist prescribing and filling of orders are in the Idaho standard of care laws. I think one of the themes we've been hearing throughout today is even from the Attorney General's office and the Department of Consumer Affairs, is really evaluating how one would practice, and is that consistent with good patient care and with the law? Would it pass a test of reasonableness? I thought these two questions from the Idaho standard of care were actually very helpful. Is it reasonable? Is it what would be considered good care? And of course, if there is a federal law, we would always want to make sure, or a state law, that we don't practice outside of that. But I thought the guidance of these two questions, again, we, not I need an autocorrect, thought these were useful. And I think the benefits have been well articulated by previous speakers. There is a fair amount of delay in care. I can't underscore that more. Calling physicians for permission. And they do find it annoying. I mean, I said it before, but I have to say that is from a team-based perspective, which is what I've practiced my whole career. Having a physician be frustrated with a pharmacist who's trying to clarify an order because it's within, how our current law is written, it does deprofessionalize the pharmacist's relationship with that physician somewhat. And so it's something to consider, because I think we've worked so hard, and the board has supported us so much in advancing our practice, that's kind of one of these unintended consequences of the way the laws currently are. Next slide, please. So one of the members of our team decided to actually weigh the pharmacy law book and the Idaho law book, just in terms of complexity. And I think this is something that's self-evident, otherwise we wouldn't be here today. But it was interesting to see the difference in the number of pages and sections, and that's why we're here today. I'm not going to belabor that, but it is a stark contrast. And just as we look at current state in California versus Idaho, some language there just to show, as I think Dr. Deng articulated, there's a separate part of the law for everything we do, whereas Idaho is much more broad brush. Similarly with technicians, and compounding really refers to USP. Next slide. So here is where we landed, and this is my last slide. So we believe that a proposed standard of care would have guiding principles, and here are some of our recommendations as to what this might look like. We defined what we call responsible medication management, that we have the responsibility to participate in all aspects of medication management in partnership with patients and or their caregivers, as well as the healthcare team. I think that's self-evident. We really believe there need to be quality assurance programs in place to make sure that we're continuously monitoring the quality of the care we're providing under the standard of care model. And we believe that that's always going to be fundamental to anything we do in the practice of pharmacy. We believe the practice should be consistent with the education, training, or practice experience, and that the practice is within the accepted standard of care provided in a similar setting by a reasonable and prudent licensee with similar education, training, and experience. Similar to what we've heard, I think, every speaker say about what does standard of care look like. We liked the Idaho guiding questions. We modified them slightly, and you can see them here. If someone asks why I made the decision, can I justify it as being the most safe, ethical, and optimal for my patient? Would my decision withstand a test of reasonableness? Would this practice be exercised similarly and by other reasonably careful and prudent pharmacists in the same or similar practice settings? So our recommendation is to support the next steps in this journey, and that a standard of care model needs to be based on evidence, guidelines, and best practices. Thank you.
Thank you so much, Dr. Shane. We really appreciate you coming here, and thanks for a great presentation. So with that, I'm going to open up really quick for the members for any questions or comments for Dr. Shane before. Go ahead, Vice Chair Serpa.
Good afternoon, Dr. Shane. Nice to see you again. Thank you for your excellent presentation. As always, you keep us informed and thinking as a board. I appreciate that. I wanted to ask you about your thoughts moving forward, how we would be able to maintain the advanced practice that we have in our state that goes beyond the quote unquote standard of practice. Some of the things that we've done in the past have been, with tech before it was recognized, we were doing that in our state. Also, your work on the bill on medication reconciliation is well in advance of what is quote unquote the standard of practice, because we think that those things should be the standard of practice, but we're ahead. So how do you see this working out for us to be able to continue to be cutting edge for patient safety and still doing some sort of moderation for standard of practice? I'm kind of lost in that section.
No, I think what you're calling is the general standards of practice of pharmacy, as well as how do we continue to advance, because we've always been proud about saying, hey, we're in California, we're doing this. What about the rest of you? I think that we continue to, and I know other colleagues do as well, explore areas of what I call vulnerability. I think the aging population, and as what I refer to, and you've all heard me talk before about what I call it the polypharmacy, polydisease, polydoc phenomenon that happens. I think we need to continue to look at the data demonstrating where pharmacy is needed. Tech, which I had the pleasure of being involved in for 13 years, was about really looking at how to leverage pharmacists to ensure safe care in hospitals by having technicians do non-discretionary tasks. I can tell you that if you'd asked me what the next thing I think we should be doing based on the years of data that we collected is that discharge med rec. If we can do, I think thanks to the board within the acute care side, and again, I'm limiting what I'm saying because there are so many other areas of practice, but we know acute care we've been able to leverage. Patients need to have a safe landing, and we're the only ones who can actually help bring together all that information at the discharge step. So my short answer to your question is, I think we need to explore where the vulnerabilities are and then collect the evidence to demonstrate the need for changes to state board regulations to continue to be the state that's ahead in protecting our patients. Similar things are needed in the area of specialty pharmacy, where patients are on chronic therapies that are very, very challenging from not only an adherence perspective, but from a safety and monitoring perspective. So I think we could do both. And I know that there are colleagues across the state who are involved in these types of advanced initiatives who would be interested in continuing to explore how do we keep, what I would say, a learning incubator and information that would demonstrate why we should continue to advance pharmacy beyond what I would call the core standard of practice, if that's what where we're gonna go. Hope that
So
helps.
just to follow up, then, how do you visualize that happening in a regulatory world? If we do not have, would we still have a hybrid then, having regulations for these areas that are beyond the standard of care, the generic practice? How would we enforce advanced practice, I guess?
Well, so we could have a core standard of practice, and then just like we have advanced pharmacy practitioners, there could still be an advanced standard of practice. And maybe with time, the advanced standard of practice becomes the core, right? That would be my, I've always felt that you have to advance and then you make it the standard. That's kind of my way my brain works. But I don't see why they're mutual, why we couldn't have both. Because some things could be something that is innovative and advanced and represents a patient need, because everything should be driven by patient needs. And then maybe it starts out as advanced and it ultimately becomes core. That's kind of what's happened with the practice of health system pharmacy in my career, where some things used to be advanced and then it became, well, no, everybody needs to do that. Just a thought.
Yeah, thank you, Rita. I appreciate it.
Thank you, Vice Chair Serpa. Okay, any other member comments? Just a reminder that we're about to go into our discussion period. So if there's no specific questions for Dr. Shane, we're gonna move to our next section. Okay, so thank you to all the presenters today for your time and preparation for the meeting. We will now open the discussion. Now, just a reminder, this is something that I think during the virtual world, it's not something we've tried yet, so it might get a little bit interesting, but we'll do our best. So, moderator, please open the lines for public comment. And what we're going to do, as discussed, commenters will have 5 minutes to provide public comment. And if any questions, commenters may also provide comments more than once, particularly if commenters after you first provided comments raise the point that you wish to comment on. The committee respectfully requests that individuals interested in doing so re-queue or raise hand so that we can call upon you. I would also like to remind everyone present that there will be additional time for comments at subsequent meetings as well, and I'm planning on to maintain this kind of setup for the subsequent meetings as well. Out of respect for everyone present, we do respectfully request that you avoid restating comments or questions you have previously provided to members. Members, during this portion of the meeting, please use raise hand feature to indicate that you would like to either make a comment or ask a question of the commenter. I've asked Anne to monitor for members raising their hand and requested that she verbally advise the moderator following each commenter. So hopefully this makes sense. Anyone who would like to make comments or questions, please raise hand or type in comment on the comment section. Members, if you had any questions you wanted to ask to all the presenters or anyone else, just go ahead and raise hand and we'll go from there.
Our first request for comment comes from Jessica Crowley. Jessica, I have sent the request to unmute your microphone.
Thank you so much for all of the presentations today. It's definitely a lot of information to consider. I'm learning a lot myself. I am a community pharmacist in a grocery setting, although I do have 11 years experience in a chain setting as well. So my perspectives do come from that standpoint. Just hearing the different perspectives, it sounds like standard of care would make sense in certain settings. However, I do have several concerns in the retail setting. One of the presenters this morning mentioned an example using the nursing board in terms of disciplinary action where a nurse was, brought in for disciplinary action, not aware of the standard of care patient to nurse ratios, but that was the standard for the hospital. So the concern from the retail perspective is where the liability for the company or the employer lies, since they aren't technically a health entity. And it sounds like we didn't really get a full answer, if I remember correctly, regarding what happened in that particular scenario. I do support the expansion of pharmacist role in patient care services. However, I think if the pandemic did teach us anything, it's that we're stretched extremely thin and we're being asked to do more and more in a retail setting with less and less support staff. So although I do support the additional patient care services, I fear that many pharmacists are going to be forced to do though with insufficient support. So just referring to the workplace survey, I believe it was something like 75% of pharmacists working in a chain setting believed they could not safely administer patient care services. So that's definitely something that I want the board to consider very seriously when thinking about this matter. And just thinking back to the ad hoc committee for investigating workplace error reduction, I think it's important to consider systemic issues when it comes to patient safety before we move forward to changing the current model that we have. And I thank you all very much for your time today.
Thank you. Thank you so much, Jessica. Appreciate your comments. I see Dr. Dang raised his hand. And go ahead, Dr. Dang, if you could please unmute Dr. Dang when you can, moderator.
Thank you, Chairperson O. I think those are some really great comments to consider as well. And I think they're both related but separate issues, but also important to keep in mind. I do just want to add for the committee to consider that I do believe that standard of care does not require pharmacists to provide services, especially when they are lacking the necessary training, resources, and/or support. And so that should also take into consideration the workplace conditions for the various practice settings. Additionally, I do want to note that the standard of care model would allow the board and other regulatory agencies to spend less time focusing on incremental changes to the pharmacist scope of practice, and thus opening up and allowing for more time and resources from the board and the legislature to focus on equally important issues of patient safety, medication errors, workplace conditions, and provider wellness as priority items. Thank you.
Thank you, Dr. Dang. Thank you for the response. Any other thoughts?
We have a comment from Anandi Law. Anandi, I've sent a request to unmute your microphone.
Are you able to hear me?
We can.
Okay, thanks. So it was great presentation. Thank you very much. I'm really looking forward to change. One of the questions I have is the AMA, the American Medical Association, of course, released a statement on March 4th about the test and treat, wherein pharmacy was, they basically mentioned that, and I can read the statement if you like, but they preferred that a clinician or a physician should be in charge of the whole test and treat rather than pharmacists, because there's so much complexity in the medications required for test and treat. Would any of the panelists be able to address that level of, almost opposition to what we are trying to do, and how you think we can address that? Thank you.
Thank you. Thank you, Dr. Dang. Go ahead, Dr. Dang. Or was it not? Oh, there.
Thank you. I'll be happy to address that as well. And hopefully there's other panelists, feel free to call on them also. Thanks to Anandi for bringing that up as well. And I think that's also going to speak to kind of that getting used to like what is the standard of care, right? So if we have medications that pharmacists may be considering to furnish, that they would consider all of the contraindications, precautions, and drug indications. Specific to the AMA's response to the federal government's test and treat program for the antivirals for COVID-19, their concerns were specifically with two items. One was drug interactions, and second was renal function. When it comes to drug interactions, I think we can all agree that pharmacists are the experts in this area. And if anyone would know drug interactions, it's the pharmacist. And so that would require the pharmacist not to only use the medications list from their own pharmacy systems, but to collect that information as a part of the pharmacist patient care process from the patient, then to complete a due process assessment of whether there is an interaction that would preclude them from prescribing the medication. And in addition, if serum creatinine is one of those screening factors where there may be a contraindication, then the pharmacist needs to take the necessary steps to attain that information, either through ordering a lab, which pharmacists are currently authorized to do, potentially doing a point of care test for a renal function, which is included as one of those tests that are available on the market, or three, coordinating with the patient's primary care provider to get a copy of recent lab results indicating the renal function. So I think that would be part of the pharmacist patient care process to collect the necessary information that they need to ensure that they're prescribing a medication that does meet those necessary screening requirements and avoids any contraindications. And if a pharmacist is missing any of that information, then it would not be appropriate to proceed under the standard of care model.
Thank you so much, Dr. Dang. Really appreciate addressing that concern. Okay, I don't see anyone right now, but members, any questions you've had that you've
President-
saved? Yeah, go ahead, Shelley.
Chairman, we do have another comment from Jessica Crowley.
Oh, go ahead, and then I'll go to Nicole after. Sorry, Nicole, I just saw you raise your hand. Go ahead, Jessica.
Hi, thank you. I just wanted to add one more thing. So although the standard of care may not require pharmacists to perform patient care services, I do want to point out that per the workforce survey, 95% of reported chain pharmacists were required to be certified or perform these services. So the concern is that even if the standard of care doesn't require it, that the employers still will, which may compromise patient safety because they will be distracted even if they don't have the proper workforce to properly provide those services. Thank you.
Thank you, Jessica. Nicole, go ahead.
Yes, I was just a comment, and this is just more from my own understanding, but from what was said in some of the earlier presentations, it sounds like if we moved to this model, a standard of care model, it could possibly make the objection of a medical board less relevant, if I was understanding correctly, because we wouldn't necessarily be working with them, we wouldn't necessarily have to go through the legislature. So opposition to us moving on a certain item might be less relevant if I'm putting the pieces together correctly. So that was just one comment. And then this is more a question that we may not know the answer to this, but could we maybe, if we did a standard of care model, include specifications about the practice setting so that there would have to be certain amounts of, say, support staff, certain workplace, I don't know, certain things would have to be met for these to be required? Could that be a possibility that might help some of the fear or concerns from the retail setting? Just some thoughts.
Thank you, Nicole. I think that is a big challenge. That's where we see as the biggest challenge really is kind of understanding what has been done, what's been the pharmacy practice for years, and then how is that transitioning to pharmacists. And I think we're one of the only boards, I say this all the time, that actually regulates businesses and professionals, which makes it extremely challenging for us to navigate this path. So it's definitely something we have to think about, try to figure out what is a feasibility and appropriateness, right? And I also just want to make sure that after the presentations, if the Attorney General's office or Eileen have any comments, or Mr. Cover, if he's still here, hoping to make sure that they can respond to some of them. Also, Dean Robinson says he has something to respond. So Dean Robinson, Dr. Robinson, go ahead.
Thank you. So the overall goal here is really to create a regulatory environment in California that maximizes the ability for pharmacists to function as healthcare providers. So we've already been given that authority as healthcare providers of healthcare services. What we want to do is create an environment that supports our ability to provide those healthcare services. So it's really not about expansion of scope. The focus, I mean, in my mind, is not let's expand scope, and but it's really let's create an environment that supports the things that pharmacists are, educated, trained, qualified to do. When it comes to, I know I mentioned the fact of medical boards being involved in many things that are written into pharmacy law, but it's that legal scope of practice that's written into pharmacy law that is so cumbersome, that is so so difficult to change. It doesn't keep up with changes in practice of healthcare. And that's why when you're looking at all of those other practice specialties in medicine or pharmacy, nobody is going to the law book to see how should I treat someone who has hypercholesterolemia, or how should I treat hypertension, or how should I manage anticoagulation. You don't reach for a law book, but when pharmacy is totally regulated based on legal scope of practice, then our hands are very much tied. And so we're not asking anybody to do any more work than you're already doing. We're trying to create an environment that supports the work you're doing.
Thank you for the comment, Dr. Robinson. I also see Mr. Mark Johnston raise hand. Moderator, if you could please unmute Mr. Johnston.
Thank you, President O and board members. Mark Johnston representing CVS Health from my home state of Idaho, where many of you recognize me as the former executive director of the Board of Pharmacy. So I've been enjoying the many references to Idaho today. I think all of the comments that I've heard today are in support of pharmacist expanded practice, and why not? We're pharmacists. The studies that everybody has quoted today all prove that pharmacists can improve healthcare if we're given the opportunity. The opportunity arises through some changes that allow us to conduct those activities, but it needs to be a holistic approach, and you really can't expect a model to change by just expanding pharmacist practice without balancing that off with a reduction in administrative burden and giving some ancillary tasks to folks that you can delegate those to, namely technicians. So I know the Technician Summit is coming up soon. I think that's terribly important to this topic, to be able to expand the practice of technicians like just about every other state has done, to expand the ratio past the most limited ratio in the nation, to remove the many administrative burdens that a law book that's the size of California places on pharmacists so that they can concentrate on their newly found expanded practice. So, I sense a vote of support by the committee and the board for expanded pharmacist scope, but that's just part of the conversation. I truly believe it needs to be a holistic approach for it to work.
Thank you, Mr. Johnston. I also see Mr. Cover's hand raised. So, moderator, please go ahead and unmute.
And really appreciate the scope of different presenters and discussion today. And I guess from a regular standpoint, and as far as when speaking to this topic in other states, I think that the important thing for us all to really remind ourselves and consider is that we've been through nearly 2 years of some of the most difficult times for all the health professions, and that pharmacies and pharmacists have responded remarkably and providing to our communities, during a very, very difficult public health emergency. And obviously, we have, just like the other professions, that we have implications of that level of where 80% of the immunizations were done through community pharmacies. So, so I think that, as regulators, and some of the feedback we're getting from consumers across the states about access to pharmacies, closures, different things, that there's a tendency to want to fix that and fix that through regulation. And I think that in some respects, the role of the board, and as it relates to this, is how do you, allow, work with all those providers to deal with that short-term situation, and address that, but not regulate or put things in that are much more long-term and long-standing, that in the end it could be a continued impediment for advancement in communities that need it more, in some cases, more than any type of practice setting. So I think that's really something I really want to reiterate is just have that in mind. And I always try to say that pharmacy has more labels than any profession I know of. We label things retail, community, chain. I think the more we do that, and the less we speak as a profession and look at how we advance all practice settings, we continue to handicap ourselves. So I just wanted to appreciate the opportunity to speak, and happy to assist. NEBP always stands ready to assist you as a member board of our association in this effort. I really applaud you all for, again, this is one committee. It's taken an entire day to really commit to this effort, and so commend you, and we'll work and support in any way I can as an association. So thanks for this time.
Thank you, Mr. Cover. Dr. Shane, go ahead.
Okay. I'm not sure if I have much to add. I just wanted to, I was listening to some of the concerns on the part of community pharmacy practice, and I think that standard of care should not be at the expense of medication safety. And I think that some of the kind of guiding principles and comments I heard made by, I believe it was Nicole, you, apologize, I didn't catch your last name, with respect to how to ensure that the standard of care is done without compromising the individual's pharmacist's ability to provide safe care is going to be important, and should be put in as a guiding principle, because employers should not be dictating standard of care. This is a professional, this is a kind of a professional blueprint we're trying to create to enable us to care for patients, but never at the expense of patient safety, and never at the expense of the individual pharmacist feeling that the employer is dictating what they should be doing. So somewhere it needs to be in a guiding principle.
Thank you, Dr. Shane. Thank you so much for the comment. While we wait to see if anyone, there's one more comment. Okay, I think Rob Geddes, Dr. Rob Geddes, I believe is how I pronounce your last name. Go ahead.
That's correct. Can you hear me?
Yes, we can. Thank you.
Okay, perfect. Thanks, President O. I am Rob Geddes, the Director of Pharmacy Legislative and Regulatory Affairs for Albertsons Companies. And like Mr. Johnston, I do come here to you today from Idaho. And so I practice here in Idaho as well as live. And I just, Idaho came up several times. And a lot of times we talk about what Idaho, where they are today, but we don't always necessarily reflect on how they got there. And we also don't always look at what are some of the good consequences that they've experienced over the past 2 years during the pandemic. And I want to just point out a few of those, just because I think that will help provide some important context to this conversation. And as many have pointed out, this is an important conversation that the decision that is made should not result from one day's conversation, but should be done over time to make sure that that you're comfortable with the direction that is being done. So Idaho, as they've been on the cutting edge of pharmacy in expanding the scope of practice for pharmacists to allow them to practice at the top of their license, over time they took steps and steps and steps to get to the point where they are today. And eventually they did conclude that they're either going to continue to go to the legislature to request for new authorization for each new drug class and category that a pharmacist could potentially prescribe and increase patient access to that medication, or they were going to change their model altogether and allow the innovation of medicine to coincide with the innovation of pharmacy. And so they did change the model. They instituted those guardrails that really sets the baseline for how a pharmacist can practice, and it's really based on the theory that the individual has to be able to show that they have the appropriate education and training to perform whatever service they are providing to the patient. So really one thing I just wanted to make sure and make clear is that there's the standard of care that is established by the peers that are performing that similar service or that similar therapy for the patient. And the standard of care model is how that is regulated. It's really getting out of the way and allowing the profession to grow. So that answers Vice Chair Serpa's question of how does California continue to advance. The standard of care model actually facilitates the advancement as new things happen in the market, as new things become available. We as a profession don't have to wait for the legislature to pass a bill that allows us to take steps to take advantage of that new therapy, that new innovation that is in the market that helps advance the care of patients. So that's really the standard of care model facilitates that process, allows it to move faster without the intervention of the legislature. And then the Board of Pharmacy is still there as the safety net to make sure that it's advancing appropriately and safely, so that individuals receive the care that is appropriate and should be done. So Idaho is at a very good point in time where they've taken many steps over the course of many years to get to the standard of care model that they are. But what's the result during the pandemic? As you look around the country, states had to issue waivers after waivers in order to facilitate and accommodate the changes that pharmacy needed to do in order to keep the doors open and keep access to patients available. Idaho actually didn't have to issue waivers. They did issue some guidance from time to time in order to guide people on what they already had permission to do, because it's still a new concept here in this state. So they did need to help shepherd people to say, hey, you already have the ability to provide continuity of therapy if somebody's out of refills and you can't reach the provider. So during the pandemic, they didn't have to issue waivers where many states, including California, had to issue waivers to facilitate the changes that needed to occur to keep access to pharmacy available and open to the public. And so that's one of the huge advantages that the standard of care model really can achieve, is that when we're encountered with a new challenge like a pandemic, there doesn't have to be a delay in the response, because we have to wait for either a board of pharmacy or a legislature to act to remove the barriers that are impeding the care for patients. So those are just a few things that I wanted to point out, and I appreciate many of the presentations today were very excellent, hit on some very important topics, and look forward to seeing this discussion continue to progress. Thank you.
Thank you, Dr. Geddes. I saw Indira, you had your hand raised. I want to make sure that you didn't have a question there.
Thank you, President O. Yeah, I do. I have a question for some of the panelists and some of the folks who've spoken. Could somebody explain a little bit more about the comparison of the state of practice in Idaho versus California? I mean, just number of licensees, the differences in practice settings, the scope of services, what pharmacists are facing in Idaho versus California, I can imagine might be different. And so to the extent that we are, Idaho has been raised many times, Washington as well. I do appreciate, I guess we have some folks from Idaho on the call as well. If I would just like to get a better sense of why Idaho is a good comparison state for this issue.
Thank you. Excellent point and question, Indira. Thanks for bringing that up. I actually was about to ask about Idaho too. So, um, anyone from any Idaho expert, if wanna, I see Mr. Johnson. Go ahead, Mr. Johnson.
Yes, again, Mark Johnston. I believe that pharmacy is a universal practice. I'm sure Idaho has 2 million people. California has much more than that. Besides population, is there, a terrible difference between the two states in America? There's 1 million people in Boise, and there's rural areas. California has rural areas. They have cities, and their cities are much bigger. But does the population make a difference to the practice of pharmacy? I mean, isn't the practice of pharmacy in America, fairly universal? So when I hear that question, I don't really understand the basis besides population, which I don't understand the argument. So maybe I'll ask a question back. Can you explain to me why California is so different than Idaho?
Well, I guess your response is that there is no real difference, is what you're stating, and I'm curious to hear people's perspective on that.
Anyone else? I see that Jazzy raised her hand. Jazzy, go ahead.
Hello.
We can hear you, Jazzy.
Oh, wonderful. Apologies, I am now back joining. I'm glad you guys are still going on, and I was able to catch the last part of this discussion. I just wanted to weigh in here and say that a point that we should be looking at is how many retail locations or how many pharmacies are in Idaho versus California, and what does that enforcement structure look like? California is a large state with lots of retail locations, retail pharmacies, other types of pharmacies, and it'd be interesting to know how many are in Idaho. And I think the Board of Pharmacy is one enforcement entity, and they have a lot on their plate. And so making sure we have other types of safety nets to ensure that the profession moves forward and we're protecting patients and pharmacists is really important. And so that's just something I wanted to state was, what does the enforcement mechanisms look like in Idaho versus California, and how many locations are in Idaho versus California, and how that all plays out, I think is very important as we talk about potentially shifting away to a new model such as standard of care, and how does enforcement look like in California versus a state like Idaho. So I just wanted to just weigh in there really quickly. Thank you.
Thank you, Jazzy.
We have
Go ahead, Mark.
our next one comes from Stephen Gray. Sorry, he piped in first.
Oh, yeah. Okay. Thank you, Shelley.
Hey, first of all, new member Indira, congratulations. You don't know me. I'm very active in the board discussions. I'm a pharmacist attorney who's been practicing for over 46 years. I'll get to your question about Idaho in a minute, but I want to go back and support what we heard from the Attorney General's office, that standard of care is not only determined by the peers and what other people in the practice and other health professionals are doing, but it's also the Board of Pharmacy has the ability to determine standard of care by setting the minimum level. And it has done so, and it would still continue to do so. For an example, the Board of Pharmacy has set a minimum standard for the patient-centered prescription label that all pharmacies have to comply with. That has saved a lot of lives and improved care tremendously in the past decade. But this is all about taking the lid off the top. As Dan Robinson pointed out, it's letting each pharmacist practice to the ability of their education, training, their setting, and their experience. And right now that's not possible because in the statute, the definition of a pharmacist says that they're allowed to do anything that's specified in the chapter. It's right in the statute. And if you don't go and change the statute every time you want to do something different, then you've got a problem, or the regulations. So back to board member Serpa, the Board of Pharmacy in California, yes, it looks at USP, but it also has the ability and would still have the ability to set more strict standards if that USP was not what the board felt was adequate to meet its mission. One of the differences that Idaho has, of course, is they have, I believe, as a rural state, a problem with adequate access to physicians and other primary care providers. And they have done some wonderful things, for an example, with the treating of flu, where they test for flu, and then the pharmacist can determine through an objective test whether it's viral or bacterial and can initiate therapy. They've saved a lot of lives and a lot of healthcare money, and they've cut, for an example, the inappropriate use of antibiotics by 50%. So that alone is an indication of one of the things that they stand out for. One of the differences also between Idaho and California, California has a statute under Business and Professions Code 800 and its subsequent parts that requires every pharmacist, every insurance company, every counsel for the pharmacist to report to the board any settlements of claims of $3,000 or more if the patient feels they were mistreated, incompetent, if there was malpractice. So the Board of Pharmacy will already have in statute and has already used in the past decades a provision where it finds out about problems when they start to become large or repetitive. And so that's one of the ways when you open this up to let pharmacists practice at the highest level of their training, experience, their setting, and their abilities, the board will still have access to make sure that these pharmacists are, practicing appropriately. By the way, that standard is $10,000 for nurses, dentists, and everybody else, and $30,000 threshold for physicians. But so pharmacists and the Board of Pharmacy will actually have a greater access to that claim. And I'm not talking about just claims that went through an insurance company. It's a claim to an arbitrator or even a claim that's settled, informally. When that claim is made, has to be reported by the licensee himself or their attorney or their liability carrier, including when they're self-insured. So those are things that already are there to make going to the standard of care very reasonable and very important for Californians' health. Thank you.
Thank you, Dr. Gray. Okay, I'll go with Mr. Johnson next. Go ahead.
Well, thank you for the opportunity to speak again. I know it's unusual. Thank you. I just wanted to answer Jazzy's question, and my information might be a little dated. It's been 7 years since I've been the exec at the board, but I'm going to have good ballpark figures. There's about 550 pharmacies in Idaho. I know there's 3 inspectors. There's 1 chief inspector who spends most of his time in the office, not a field person like the other 3. There is 1 controlled substance investigator. So the controlled substance investigations fall to that person. So arguably there's 5 people. We do strive to get into every one of the pharmacies every calendar year, and most years we do make that goal. Of course, we do regulate other folks like wholesalers and whatnot. So there are some other drug outlets that we have to add to that inspection cycle. Overall, I think we are, I'm going to say I know we are in pharmacies, at least a larger breadth of pharmacies more frequently than in California.
Thank you, Mr. Johnson. Thanks for the response. Okay. Any other member questions or comments, or anyone else would like to speak? So I understand this is a very preliminary discussion, obviously, so we'll have a lot more opportunity, but I myself, since Idaho is brought up, I just have some curious questions. I'm not an Idaho expert, unfortunately, so I don't really know how they practice pharmacy with the standard of care. I know that a few years ago, they adopted some protocol before I believe standard of care went into effect. Please correct me if I'm wrong. Just so like I believe Idaho community pharmacists are able to now prescribe albuterol, some flu medications, some antibiotics for UTI. But obviously, those were protocols going back a few years ago. So now, I have some, I think Dr. Geddes might be, or Mr. Johnston. If you could just explain, like, what does that practice entail now? Because what my struggle is understanding a pharmacist, of course, should be given autonomy, and not, if they have knowledge and skills and abilities to practice and provide those services, should be. But what I'm trying to wrap my head around is, what if a corporation has a policy, specific directions that is set for pharmacists to perform certain ways? Where does that, how is that going to lie in terms of enforcement, or in terms of what if something goes wrong? So, that's kind of a struggle that I'm having hard time wrapping my head around. But Mr. Johnston or Dr. Geddes, if you can just kind of at least share how it's being practiced over there in Idaho, that would be helpful.
Yes, Mr. President, this is Mark. CVS Health has 3 pharmacies in Idaho, so I'm not sure I'm the best one to answer from an employer perspective, and I might have to ask Rob to weigh in more heavily there. I can explain the stepwise approach to how we got here that Rob had alluded to. In the beginning, it was not an easy task to accomplish to get prescriptive authority. I was executive director, and I went to the legislature, and we got prescriptive authority, use the P word, not furnish. We use the P word for one of the first times in America to be able to prescribe immunizations, which sounds, so small a step these days, but back then it was a really big step. Believe it or not, dietary fluoride supplements came next because the dentist wanted to get fluoride in the mouths of kids that were on wells in the rural areas. And there weren't as many dentists, there were more pharmacists, and we got together and got that allowance. It grew into naloxone and EpiPens and a number of other categories. At that point, I had left for CVS, and my counterpart took over and really pushed the allowances. And he got an allowance to write, statutory allowance to write in rule categories that could be prescribed, or in some cases, individual drugs. And that was a big challenge with the Board of Medicine. There were many contentious meetings, and ultimately, the rules did pass with a number of different categories that we'll call minor conditions and ailments, as well as items that there was a CLIA waive test for that Steve just alluded to that you could prescribe off of, and previously diagnosed conditions. So if somebody with diabetes came in, as pharmacists, we don't diagnose, but we certainly could, continue that therapy and monitor and prescribe from there. After a couple of years of expanding the categories and expanding the categories, we went back to the legislature and just asked for basically full prescriptive authority. At that point, there were restrictions, and that there still are. No controlled substances at this point. At one point, there was a restriction on biologics based solely on cost. People were concerned with compounds. There was a restriction on compounds. There's a bill in the legislature right now that would remove those final restrictions, and then we'd have to go in and remove them from Rule 2 because they're repeated in Rule. So this whole process is really still ongoing at the legislature, literally this day, as that bill's being heard that I mentioned. And it started in 2008 or 9 with that very first category of prescriptive authority. So, it's been more than a decade to go from point A to point B where we're at.
Thank you, Mr. Johnston. Dr. Geddes, if you could just also add to whatever you could, that would be great. Just curious also about the practice settings in Idaho, how community pharmacy, what they can do.
Sure. It's a great question. Glad that Mark went ahead and gave the background. He's definitely more equipped on the actual steps that we went through there. To answer your specific question about how does a corporation handle this and how do we do this and so forth. So our company, Albertsons, we've got 39 pharmacies in Idaho. And we now offer several different services to the customers as they need them. Some of the more notable ones would be prescribing antibiotics for UTI, prescribing antivirals for cold sores, prescribing hormonal contraceptives for patients. Those are kind of some of the marquee ones that the patients seem to have gravitated towards pharmacy to receive their care in cases where their doctor may not be open, et cetera. So what we have done, so the way that the Idaho regulations are set up, they are very high level and really set that minimum expectation that appropriate training is in place, the education is there, and the experience is there to be able to safely provide these services to a patient. So for us as a company, as a corporation, we need to make sure that that in order to protect ourselves from a liability standpoint, that we have a little bit more structure that's in place. So we have developed protocols for our pharmacists using our clinical experts to help guide them. That includes the training that we need them to undergo before they're eligible to participate and provide that service to patients. So as a company, we've taken it upon ourselves to implement stricter guidelines than what the Board of Pharmacy requires. So there again, the board set the minimum expectations. We've set a little higher standard for ourselves to make sure that that we're comfortable with the individuals performing this in a safe and appropriate manner. And we provide that training to facilitate that the individuals are able to go ahead and provide this safely. Now we've very similar to what Mark had mentioned. At the same time that pharmacist scope has expanded, the scope of practice for technicians has expanded as well. We've been using technicians to immunize in Idaho since 2016. And that has helped to relieve some of the administrative work off of the pharmacist in order to safely provide these services as well. We use our technicians also to receive new prescriptions verbally when necessary, facilitate transfers between pharmacies when it's a non-controlled substance, call to clarify information on a prescription that doesn't require professional judgment. So if there's a question about the quantity or maybe the number of refills that were written on the prescription due to just illegible handwriting. So in order to do that, we have increased the scope and training for our technicians so that they can adequately support our pharmacists as they take advantage of this increased scope that Idaho has created. But what I can assure you is that that we do a good job as a corporation to provide that safety net to our employees to help them feel comfortable and confident that they can do this safely, provide them the support that they need as well. Now, something that's a key thing that's really helpful is now that Idaho has taken these steps, we just launched a pilot with Blue Cross of Idaho. So the first one, at least that I'm aware of, one of the first payer pilots to pay pharmacists now for providing these services. So not just being paid to dispense the medication, but actually being paid for the consultative services that we do with the patient. And this, in our opinion, if we can successfully prove this model and other insurances adopt it, it will help speed the adoption of pharmacists taking advantage of the increased scope in the state, and then hopefully help other states see the value that pharmacists can provide to the overall healthcare home. If you have any other further questions, happy to answer any of those that you may have.
Yeah, so just before I let you go, so just one more follow-up on that, Dr. Geddes. Thank you. And so I'm just, it always helps just to visualize. And I'm sorry, I'm not trying to focus too much on community pharmacy setting, but I think that that'll be a difficult area for us to navigate through when we discuss standard of care, more so than the health system or any other setting. So like in Idaho now, pharmacists are able to quote unquote prescribe if a patient comes with a medical record, maybe saying that they have diabetes, or how would would that determination be given to the pharmacist to decide how far they feel comfortable of taking a further step? How does that in real world example, like how far and how much, and how is that actually regulated, or is it regulated, or is there not regulated at all?
Yeah, there's not regulations that regulate down to the specific categories that you're going to prescribe. The limitations that they do have in place is that it has to be a minor self-limiting condition, can't be a new diagnosis. So somebody couldn't come into a pharmacy and say, I think I have diabetes, and then have the pharmacist go through the process of determining whether or not that person in fact has diabetes. That would be a new diagnosis. That is outside of the guardrails, the minimum guardrails that the Board of Pharmacy has put into place. But let's use UTI, for example. It's minor and self-limiting. So patient can present to the pharmacy and make it known that they have suspected UTI, and then through gathering patient history, taking vitals, etc., they're able to walk through and determine if in fact that individual does have a UTI, and then if so, prescribe a short course of antibiotics. So whenever you're working in retail, you may be familiar with when the doctor sends over a prescription for an antibiotic. It's usually a 7 to 10 day course, but which is actually longer than is likely necessary based on guidelines for treating UTIs. So we have structured the formulary that you could say for our pharmacists to choose appropriate antibiotics based on the patient's criteria, and only prescribe for what is recommended, the recommended length of the course of therapy. And so that helps guide that decision. So the Board of Pharmacy doesn't get into the details of which patient would be eligible for that service, whereas as a corporation, we have taken a stance that we do determine who is eligible for receiving that. So we've created inclusion and exclusion criteria, so that if the patient does not meet that inclusion criteria, they would our pharmacist would be required to refer them to a primary care provider or urgent care, depending on the circumstances. There's also situations that if they have certain symptoms that would be outside or inconsistent with a UTI, they would have to also refer that individual for more advanced medical care. So we're not trying to perform brain surgery in pharmacies in California, or sorry, in Idaho. But we've taken a very stepwise approach as we're also getting comfortable with some of these models as a company, and as our pharmacists are getting comfortable with them, that we're doing it from a very appropriate perspective, as well as gaining the trust of the patients in the community, so that they recognize us as a provider that they can turn to when they have a need, when they may have symptoms over the weekend, or after hours when their provider may be closed for the day, that they don't need to wait to the next day to seek care. And I can tell you that we've had good success. Our pharmacists have done a great job navigating those discussions with patients and determining when is it appropriate to refer, when is it appropriate for them to go ahead and prescribe. And in some cases, the outcome of that consultation means the person walks away with no prescription, just like they may in their doctor's office, because there's not a need to prescribe therapy for the individual. One step further that I think you'd find helpful. So as a corporation, we've recognized that we've moved into new territory, and in order to make sure that our pharmacists are following both our guidelines as well as any state guidelines that may exist, we do self audits. We are auditing the interactions to make sure that that the prescribing was appropriate, to make sure that that they followed the steps that were outlined. And then as deficiencies may be identified, providing additional coaching to ensure that that individual, the next time they have an interaction with a patient, is likely going to have a better outcome. We haven't had any significant issues to date so far in the state where there was any significant poor outcomes for patients, which really goes to show that pharmacists are educated appropriately to provide this care to patients, and can do so in a safe manner, and especially when appropriate safety measures are put into place. And the reason that I say that is that the standard of care model also requires individuals to self-regulate, corporations and entities and healthcare facilities to self-regulate, to make sure that they are accepting the risk that they're undertaking and then putting appropriate measures into place to mitigate those risks that they may face. So those are some of the steps that we've taken to try and mitigate those risks and ensure that when a patient seeks care from our pharmacists, that they're going to receive appropriate care and have good outcomes.
Okay, thank you. Thank you so much for the comments, Dr. Geddes. And Dr. Deng, I see your hand raised. Go ahead.
Thank you, Chairperson O. I just want to provide some more context and information to a few of the items you asked. So in my role at USC, I'm also the residency program director for our PGY1 community-based pharmacy residency program, which has been training community pharmacists in residency programs since 1999. And we have residents currently placed in health systems, hospital pharmacies, independent pharmacies, and corporate grocery store pharmacies. So all the practice settings in outpatient. And so we've had experience placing these clinical services in community pharmacies all across the spectrum. And so just kind of providing some context for how those services are also provided. And thank you to Dr. Geddes for your experience at your area as well. Thinking about some of the staffing considerations, we at our pharmacies have kind of two different models. If you say that we're looking at the staff when we have clinical services, one is at some of our pharmacies, we have a separate clinical staff pharmacist who handles these clinical services, so that the pharmacist who's responsible for dispensing and medication verification in the traditional pharmacy operations, that their work is not impacted. And so that's one of the strategies that we've taken at our pharmacies to ensure that we can safely produce both medications that are dispensed and clinical services that are being offered. In the other models with some of our pharmacies, we have that integrated model where the pharmacists do the dispensing and the clinical service as part of their daily responsibilities. However, they do have the authority and independence to decide when it is safe to provide a service. So they set their appointment schedule, for example, and they can dictate when it's appropriate to schedule a patient for a particular visit. If a patient comes to request a service, if there's not ample resources to support that time, they can schedule the patient for a later time and handle kind of that situation. And so we in our systems give the pharmacist that authority so that, again, it's not negatively impacting their workflow. So I just wanted to kind of let you know that we do have those two models kind of existing at our current pharmacies where these services are being offered. And also in addition to that, I think building on what Dr. Geddes mentioned, you had asked about the corporate policies and if that maybe wouldn't be in line or if maybe something bad happened to a patient using the corporate policies. I think what we would see in especially the community setting when we do have these company policies that dictate various clinical services, that that the companies are able to demonstrate that they were put together using sound evidence through a quality assurance process, that these policies are put into place with that in mind. So for example, in health systems and hospitals, we know that there are safety committees and clinical committees and P&T committees that also review the protocols that may be utilized by the pharmacy departments. And similarly, in the community pharmacy or corporate setting, if there are going to be P&Ps regarding clinical services, a similar mindset should be taken to place where, for example, at our sites, we do have a clinical committee made up of not only the administrators, but also the pharmacists who are providing the services, so that we come together and brainstorm the current evidence and how it would exactly be implemented. So I think, basically what I'm saying is that there should be the business should be able to demonstrate that the policies they're putting together are one, current, 2, sound based on evidence, and 3, that there is a process that's in place that involves various stakeholders from within the company to ensure that it is an appropriate policy and is not just something that would be contrary to evidence or that would lead to patient harm, if that makes sense. And then the third item was just that also, as I mentioned in my presentation, standard care wouldn't be an open-ended authority. We would definitely look to the board and the state to provide those safety guardrails, and some of which Dr. Johnson and Dr. Geddes presented, but also mentioning that the board could also consider establishing the standard of care, not only around what's clinically appropriate, but what's operationally appropriate in terms of necessary support staff if there are the provision of these clinical services in various practice settings. Thank you.
Thank you so much, Dr. Dang. Nicole, go ahead.
Yeah, I was just going to say it sounds, and thank you everyone for your comments, very, very helpful. I was just going to say it sounds like there's a lot of overlap too for our medication error and workforce committee that we could take some of these conversations to. I'm just getting the impression that this doesn't exist in a silo, and we're going to have to do this work across a lot of the other work that we're doing if we decide to go forward. That was all.
Thank you, Nicole. Okay, so just again, we will have a lot more opportunity to discuss. This is a very complex topic, obviously. So I think, but I just want to make sure, since it's a great opportunity for anyone and everyone to speak on this issue, I will just make sure that I'll give it a little bit of time before anyone else has anything to say. And hopefully we can have all the presenters come to all the meetings, because I think it would be great. But I understand you all are extremely busy. So, but we would love to have you all at every meeting to participate and provide your comments and thoughts, because your presentations were great. So thank you all. Okay, Shelly, I don't see anyone else queuing up, and I don't see any comments. So I think we're ready to move on to our next part. So, okay, thank you. With that, we're almost done. Moving on to agenda item 6, discussion of next steps. So obviously, having received presentation and heard discussions, we are needing to solicit your thoughts on what is needed for our next steps. Obviously, we have a lot of work ahead of us, and we need to figure out what kind of directions and what our mandates are. And our mandate is pretty clear, is to write a report on feasibility and appropriateness if transitioning to standard of care is appropriate. So as a committee, we have a lot of things to discuss. And so I will open up for thoughts and comments. Maria, I see your hand raised.
Yes, I just have a process question, because we are a committee of the board, although you are the president, so you run both. Process, I guess, for Eileen or for Anne, what is the authority of this committee? And how do we interact with the full board, and how often do we update them or get their approvals?
I'll answer the authority question, and then maybe you can have a discussion about how often you're going to update the board. This is Eileen. Obviously, as a committee, you only have the power to make a rec to the board. The board is going to have to be the one to approve the approved report to the legislature, asking whether, movement to a standard of care enforcement model is both feasible and appropriate. So I don't know, there could be some times where, and I may ask Anne to jump in here as well about what she thought, or also what this committee thinks about whether you provide updates to the board as you start to make decisions to see if they agree or don't agree. But I don't know if Anne's given some thought to that too with respect to the process.
Hi, yeah. So I think that the standard for this board is the committees taking typically the deep dives into the policy discussions and then reporting back to the full board. Sometimes the board feels comfortable with where the committee is going and just encourages the committee to continue its good work. Other times they may provide more specific direction back to the committee on different areas or aspects that they would like the committee to take that deep dive on. So I think that the reports should be very routine, and I would recommend that they occur at all of the quarterly board meetings while this committee continues to exist. But in terms of where the committee goes, I think potentially offering recommendations to the board may be helpful for it, not only so that it understands the education and all of the great information that you've received today, but also maybe where you believe the natural next progressions need to occur. I hope that's helpful.
Thank you. And Maria, does that kind of help your thought process?
Yes, it does. About the routine reporting. Now, I guess my questions are going to be is more about our process as a committee. Are we going to have time phases? Like it seems like an elephant. You can only take one bite at a time. We can't just attack it all at once. So, what's the first bite?
Right. So here's what I was thinking is how we do sunset reports is probably what I'm kind of thinking. So unfortunately, I trust Anne and our board staff to be able to extract all the things we talk about and say and the presentations and the things that they say. And they'll be able to kind of compile all those thoughts into some sort of a sunset report kind of a document that we could get started at staff level, because honestly, I don't know how we would write a report talking here. So I think it have to start somewhere. So my thinking is we have great questions that were raised by Nicole, you, and Indira. Excellent questions. And the questions that staff have probably also in terms of what they think is our questions that needs answered. With those questions, maybe staff can draft some responses and thoughts that are gathered by presentations and speakers that came here from also us. So we would have some sort of draft that we can start. So like Sunset Report, it has background, it has, things that are at issue at hand, lots of questions listed that are raised here. We would have detailed responses that are factual, scientific, hopefully, that we could bring it to us so we can dissect, read, and try to, go on about what are our thoughts from there. So that's kind of what I'm thinking. I'm not sure if there's any other ideas. And what do you think? I mean, writing a report, I feel like that's just we have to start somewhere. So obviously we gotta make you do more than what you're already given to do. So what are your thoughts?
So I think potentially some of the next steps are, I think that there's a couple of outstanding items that staff needs to do some research on, and if stakeholders want to provide information as well that we can, consolidate and present. I think that probably the next step in the process is, now that we've got some educational foundation and some thoughts from stakeholders, maybe the next step is really kind of taking a deep dive into some of the policy questions that are really going to probably be necessary for the board ultimately to be discussing in its legislative report back to the legislature. So I would suggest that potentially the next meeting, if there's additional presenters that you'd like to hear from, if you give us that feedback, we're happy to try to arrange for those as well. But perhaps the next step is having this great foundational knowledge, and seriously, great presentations today, right? It's kind of taking all of that information and really starting to think through what or if this could work in California. And I think that we can take a couple of different approaches to those questions. I've heard a couple of different perhaps approaches based on some of the different comments. So if the committee feels comfortable, potentially staff can work with the chair of the committee and kind of establish what our process is going to be in terms of really looking at those policy questions. And I think some of them are going to be pretty tough, right? It's not an easy issue. So I think probably the next committee, if everybody feels comfortable with the level of education, maybe the next step is really kind of looking at taking a deep dive into those policies, because really at the end of the day, the guiding light for the board is consumer protection. And so making sure that we're looking at it 100% through that lens.
Sounds good. That sounds great. Indira, Maria, Nicole, any thoughts? Nearing the end of the day today. It was a long first day for you, Indira. Thank you for hanging in there. Nicole?
Yes, thank you. I guess where I'm, I don't know, struggling is the right word, where I keep going to is, you know, we're definitely concerned about consumer protection, but I also just think about the ability to have a positive impact on the people of California, which doesn't technically fall under protection, but I just keep thinking of all of the potential ways that this could bring better healthcare access and outcomes to so many people. I thought something that really clicked with me is talking about adding the fluoride treatment in Idaho, because that was a particular need that was specific to that area. And we have so many of those subsets of need in California. You know, we have migrant workers, we have huge cities, we have very rural areas. So it just feels like there's a piece to this, is that we can bring, it's not specifically protection, but we can bring access to healthcare to people who really need it. I know that's not necessarily our mission, but I can't get past that thought. I feel like that has to be brought up in the report and kind of in the way that we're thinking about this, that we can really help people in a way. So that's where I'm at.
Well, Nicole, I think that we can definitely bring that at a holistic level. So I mean, I'm sure we can discuss that in the report. So from here, I think where we go is that we'll try to have some topics. I'll work with Anne to try to have some agenda items that would gear our discussion in more specific ways for subsequent meetings, hopefully. And so we can get some parts of the report started. It's probably a little early to get started, but we'll try to, and we'll also still solicit some information from stakeholders, from other board members, and we'll try to see where we land. This will be a long process, but obviously we don't want to just be at meetings talking and not have any substance to report back to the board or the legislator. So, and for us, timeline is a little tight, actually, I think, by the middle of next year. So, and we have about 4 meetings scheduled this year, including this one. We also have some possible challenges coming up because we may have to try to meet in person next month. So hopefully we'll have all that details ironed out so we don't have problems with quorums or issues with attending meetings, so we can continue to proceed. All right, with that, I'm gonna open the line for public comment one more time. Shelley, I'm sure everyone's spoken today that wanted to speak, but one last time since it's agendized.
All right, we've got that Q&A panel open. If anybody would like to make one final comment, please use that Q.
Yeah. Oh, go ahead, Shelley. Sorry.
Okay. Use that Q&A panel. Click on that Q&A icon, typing the word comment into the text box and sending that to our panelists. And for our call-in users that do not have access to the Q&A panel, you can raise your hand by dialing *3.
I see Dr. Geddes. I think if you could please unmute him, that would be great, Shelley.
Yep, sent him the request.
Thank you again. I just had one final thought, just from a procedure standpoint, and maybe to help you along the way to being able to get to some conclusions for this report. I did test as this committee got formed and as the request for comment and people who would like to provide presentations to this committee was extended to the public. I did test the waters to see if the executive director of the Idaho Board of Pharmacy, as well as some of her support staff, would be willing to engage and help go through some of the process of what did they do, what were some of the pitfalls that they encountered, what were some of the questions that they had to really solve to overcome some of the barriers. And they would be willing, and I can help facilitate that. There's probably 3 people we would maybe target for your next meeting. If you are amenable to that, I can work with Anne separately outside the meeting to see if we can coordinate them, providing just some important context and be able to answer some of those questions that you said that you may not have to take the word of Mark and I to believe how it is here, but they could maybe expand on some of the topics that are more relative to the board and the operations that they undergo to facilitate this type of a model.
Sure, that sounds great, Dr. Geddes. Yes, go ahead and please connect with Anne, and hopefully we can get some Idaho folks. And matter of fact, any other state, Washington, and anyone else who's discussed this, thought this through, we're always hoping to listen and to see what would make it better for California consumers and patients. So anything to help us navigate would be great. So thank you. Thank you for participating today. All right, so I will work with board staff to prepare for our next meeting, which is scheduled for April 19th of 2022. As of right now, that is scheduled to be in person. Additional information on this meeting will be released when available. And then we have July 13th and October 25th, 2022 as our next 2 meetings. I would like to thank everyone for your time and participation, and the meeting is adjourned. I really appreciate all of you, and we will see you all next week at our petitioner hearing. See you all, and thank you all. Have a good day.